I think you can see why the Colorado School of Public Health, under the leadership since 2017 of our speaker today, Dean Jonathan Samet, is now considered one of the top schools of public health in the country. It is really my great honor to introduce Dr. Jonathan Samet, who is an internationally renowned leader in public health, especially in the areas of cancer prevention and environmental health. His accomplishments and awards are too numerous to mention. Dr. Samet's work as the editor and author for the reports of the Surgeon General on smoking and health alone puts him in the ranks of the giants in the world today of medicine and healthcare. In most specialties, many physicians caring for patients consider themselves successful if they've saved a handful of lives and reversed or prevented the progression of disease in a few hundred patients a year. Dr. Samet, and I don't think this is hyperbole at all, can count the lives saved and disease prevented by his work in the tens, if not hundreds of millions. Dean Samet is actually now a fellow Boulder citizen. It was our great fortune, and that of the Colorado School of Public Health, that his son, Matt, as a world-class climber, came to CU and never left. Still at it, Matt is currently the editor of Climbing magazine, and John is now looking forward to the birth of his third grandchild. So please help me give Dean Samet a warm virtual Boulder Rotary welcome.
Okay, thanks, Gary, so much for the very nice introduction, and I enjoyed having breakfast with you yesterday. And thanks to the Boulder Rotary Club for the generous donation we just heard about. I actually looked at contributions from Rotary clubs in Colorado to the School of Public Health, and putting all the gifts together, it's a lot, reaching about $90,000 plus in hand at the moment, supporting activities throughout the state, and in fact, with strong support to our global health program. So we are very grateful, and I'm pleased to be here. When I was being recruited, there were really two things that were driving my coming. One, the opportunity to lead the Colorado School of Public Health, and who's going to turn down a job after your then 7-year-old grandson says, "Are you going to come live near me?" So the recruitment, I think, was strongly led by Ivan at the time. So we'll get started with a presentation, and I'm going to dash through some things. And what I'm going to do is tell you a little bit about the school, tell you about some of the things we've been doing with the pandemic, and then talk about sort of the pandemic, some of the work we've done with modeling, and where we are now, and we can talk about where things might go as well. Now, here's your first challenge: what is public health? Nobody has to answer it unless somebody wants to be so bold as to step into this. And I hear some of you I know have public health training, but when I came, I found myself in an event at the Chamber of Commerce mixing, and people would say, "Well, what do you do?" And I'd say, "Well, I'm the dean of the Colorado School of Public Health." And I learned there were two questions that immediately came. One is, well, what is public health? And there I had to deal with sometimes the challenge of saying, yep, it's more than restaurant inspection. And the second was, oh, we have a Colorado School of Public Health. And then it got even more complicated for me. But now we're at a point where things need no explanation. This is a cartoon from 2001 when we had the anthrax scares from the New Yorker. And it was so typically brilliant of you to have invited an epidemiologist. My personal background is both pulmonary and critical care medicine and epidemiology. And I've spent a lot more time explaining about what an epidemiologist does than what a pulmonary doc does. So now, courtesy of the pandemic, we don't have to explain who we are and what we do. And when I talk to our graduating classes now, part of the message is you are in the right profession at the right time. So let's go back to when the world changed. And these are some clippings back into the end of December 2019, now 18 months ago, when this pandemic began to appear. And these are some of the clips from then. And of course, by mid-March, the pandemic's path forward was very clear to all of us in public health. So being at the School of Public Health at that point, we certainly thought about what we should do and how we were going to do it. And I'll come to that. A few unique things about our school. We are a collaborative school. So when the school was founded and got underway in 2008, growing out of existing initiatives, we were formed as a collaborative school. So we have the Anschutz campus with an undergrad program we collaborated in at the UC Denver campus, CSU, where we have perhaps 80 or 90 students, and then the University of Northern Colorado, where we have a program as well that gives great emphasis to community health. So unique to us is this three-school organization. We are the School of Public Health for Colorado, and we're really the only sort of fully formed School of Public Health in the Rocky Mountain region, which was one of the appeals for me, coming to a school that has a place-based mission. We have the three universities, as I mentioned. At Anschutz, there are 5 departments. We look very much like a typical brick and mortar School of Public Health. We have more than 600 students. Students are turning to public health now. It's not surprising that numbers are going up at the Colorado School of Public Health and nationally. We have about 180 faculty across the three campuses. So we are a mid-sized School of Public Health, and we are proud that recently we hit the top 20 of schools of public health, ranked with some other colleagues at number 20. We have multiple centers and organizations. Only a few are listed here. We have a major prevention research center funded by CDC that's sited in the San Luis Valley. We do a great deal of regional training. We have our Center for Public Health Practice. Our Centers for American Indian and Alaska Native Health is the go-to place for health, public health, and practice with the Native populations. So we have a deep set of resources and a wide range of research in progress. It really ranges from molecular up to global and global policy. So when the pandemic started, we were well situated, poised to do what is inherent to our mission, to see what we could do to help out with this extraordinary event, and one that's clearly going to have lasting input and impact on all of us. Shortly after the pandemic hit, literally within days, hit Colorado, we partnered with the Colorado Department of Public Health and Environment, CDPHE, and the governor's office in modeling the pandemic and saying what's happening in Colorado and where could the epidemic go in Colorado if people don't wear masks, if we distance, and so on. And I'll show you some of that work. So for more than a year, I guess now we're up to about 15, 16 months, we've met weekly with the governor and his team looking at what we need to do to be sure, essentially, that we did not breach healthcare capacity. We have hired, with CDPHE, I think the largest number, about 50 students to work as contact tracers. We've been extensively involved with local public health, including Boulder Public Health, to help out with models, data analysis, consultation. Just last week, or this week actually, I organized a meeting for our local public health agencies on schools and ventilation and wearing masks. We've had a wonderful series with the collaborative series with the Denver Museum of Nature and Science, 30 sessions, and I've forwarded to Cassidy a compendium of the summaries of all the talks that were given. They're really interactive sessions. And the museum did a terrific job of putting these together. And I think if you want to have a readable resource, particularly paired with the presentations, which are all recorded, on topics, you may find it of interest. Some of it is now historical, like wondering about what vaccines might come. And of course, here they are, one of the extraordinary benefits of the pace of the science that has been done. And we have, I think as a school, just tirelessly responded to media requests. So turning to the modeling, we'll say a little bit about what we have done and show you the kinds of results that we produce. We've, in a sense, moving on to other things because we hope that our epidemic curve, which is descending, will continue to descend. But shortly after the pandemic hit, as I mentioned, we put together this group. It's actually been as large as 13, 14 people from the medical school, the School of Public Health, the Denver campus, and also Boulder and CSU. And sort of pictured here are a group of people who include mathematicians, people from public health, policy, and other backgrounds. And we've worked pretty tirelessly over the year and a half, sometimes with very light night effort as we sort of ran last minute runs to get stuff ready for the governor. Now, the idea of modeling is simple. It's stripping down nature to its basic elements so we can talk about how it works, how nature works with the pandemic. This is Picasso stripping down a cow, a bull, as my wife has pointed out when I said it was a cow, everything is there, to its basic elements. And that's what we do with the modeling the infection. In fact, some of the ideas are quite simple. At the start of an epidemic, this one, SARS-CoV-2 comes, we were all 100% susceptible. And the way the epidemic plays out is we go from being susceptible to infected. That's this curve here going up and down, and then recovered. And of course, with this epidemic, we know that there's another box here. It's sick and going into the hospital. And there's another box after that, unfortunately, which is sick, hospitalized, and deceased. So those boxes are in our models too. But mathematically, we know there's a certain rate at which people going from being susceptible to infected. One of our worries about these new variants is that they are more transmissible. So the rate of going from susceptible to infected may go up. And for some of them, we're worried that the virus is more virulent. So the rate of going from infected to recovered slows down, or from going infected to deceased goes up. So all this is built into our model, and we do a so-called SEIR model, a susceptible, exposed, infected, and recovered. And this is sort of the guts of the model that we've used. It's varied over time, but essentially all these arrows turn into differential equations. I'll get a little mathy here. And we use those and fit our model to Colorado's data. And in looking at different scenarios, we varied things like distancing, how people behave, use of masks, epidemiological control measures, what is the impact of contact tracing. We actually take a close look at behavior using these very large mobile phone databases. So we now know how much time people are spending at home. Are they starting to move out of homes? Are they going to bars and restaurants? And so on. In fact, one of our discoveries early on was that there were lots of people in bars from 10 to 2. We thought they might not be wearing masks and adhering to social distancing. And the governor restricted the timing of bars, when the last call was. This goes back to last July, and this is just an example of what we do. These are real data on the trajectory of hospitalizations. It was coming down, 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 and it started going up rather steeply last July. And with concern about this switch from doing very well to a rise, we then went on to say, well, what if we continue this rise and produce curves like this? This is ICU bed need, and this dashed line is our capacity. And what you see is that if we were to stay on this model trajectory, we were going to go above the dotted line. Not good. And a goal in all the pandemic management has been to assure that our medical care is adequate. So this led to an emergency meeting about what needed to be done and how we could get back off these steep curves to the ones we wanted to be on. Unfortunately, this was brief and things did turn around. So let me give a picture of where we are now, and I'm going to go global down to Colorado and local. So this is this extraordinary burden. I can assure you that there's massive undercounting. About a month ago, I gave a talk for a medical school in Egypt, which has 100 million people. At the time, they said there had been 13,000 deaths from COVID-19. In Colorado, with our 6 million people, we were saying we had 6.6 million, about half of that. So globally, the undercount is extraordinary. And we have yet to see the pandemic really surge, and hopefully it will not, in sub-Saharan Africa, where medical care will just not be able to keep up. There are hotspots. They change from time to time, depending on variants and control measures. This is a picture now. Brazil remains hot. Argentina, again, poor control measures. And, right now, of course, the United States is looking good as the pandemic has declined. It's, of course, varied regionally, but every place has been hit and hit hard. And of course, here the circles are proportionate to the burden, which tracks with the population. And again, we've seen this sweep across the country. Now, where do we stand? This is a picture we put together every week. This is the hospitalization rate going from the state that's lowest to the highest. And you can see we are number 9. This is this week. We're blue because our curve is dropping. And right now, most of the states are blue because the epidemic is falling across the nation. But we're still a little bit on the high side compared to our colleague states. We've crept up over the last couple of months. So we still actually have a fairly high rate of infection going on in Colorado communities. This is what our epidemic curve looks like. Again, the cases, and we've had multiple waves, and the deaths, they always lag, but certainly we've had our peaks, particularly the December, January peak. And this is hospital admissions, which we track and what closely is what we use for our modeling. So we had the earlier surge, of course, our first one back in March, April, May, that declined. The lowest in here was about 126 Coloradans hospitalized with COVID-19. Here we were up at 1847 or so. And then we right now are around 300 plus. So we're still well above our summertime low, but I'm hoping we are going to progressively drop. We've had a lot of little starts and stops over the last month, but I think now vaccination is winning out, even as everyone knows we return to normal and you can return to the Boulder Country Club. Now, the vaccination story, I think, first of all, it's remarkable that here we are, 16, 17 months into the pandemic with the United States, the problem of having more vaccine than people are actually using at this point. At the start of the pandemic, when people asked me, and my lay public health person opinion that it was going to be several years before we had vaccines, it's extraordinary where we are, both in terms of development of highly efficacious vaccines and getting them out to the population. So, looking across the country, there's a patchwork, but we are doing well. And I think you all know that President Biden has the goal that we likely won't reach of 70% having at least one shot by July 4th. But you can see the distribution on this heat map, which varies across the country, and we'll come to Colorado. When we look at vaccine administration, I think you probably all know that the rate of administration has declined greatly. To get to 80% by September 1, we essentially have to double our pace of vaccination in the state. And by and large, again, the Pfizer and Moderna vaccines have been the most widely used. We're not reaching everybody uniformly, and these are data by age group, just showing the rate of vaccination compared to the percentage of the population in that age group. So, for example, among the Hispanics in Colorado, there's a lag with only about lagging with about 50% lower rate of vaccination in that group compared to what we would like to see given the population size. By age, of course, older people were targeted first, and that shows up. Again, of concern is getting particularly has been the 20 to 39-year-olds vaccinated. Now they're in the 40-ish% overall in terms of vaccination, and they are substantially contributing to infection in the state. Why vaccinate? Of course, it's epidemic prevention. These are the 15 largest Colorado counties, showing the rate of cases and of hospitalizations on the right against the percent vaccinated. And you can see, of course, the inverse relationship, very clear as to the benefits of vaccination. Mesa is an outlier, and Mesa may be an outlier now because it's the county most hit by the new Delta variant. And of course, it was first identified there, and most of the cases being seen right now in Mesa County are the Delta variant, and we'll come back to that. So when we look across the state, there's quite a patchwork, with some places doing much better. The darker the color, the better, and some not doing as well. The southeast, south central areas in particular have had low vaccination rates, and historically the highest infection rates. This is a look. We have these local public health agency regions, and just these are age curves showing the rate of vaccination by age. And I think the main thing I want to show you here is there's a great deal of variation around the state. Those areas that are lower for older people are lower for younger people. And part of the challenge right now for CDPHE, the medical and public health communities, is getting through the factors that are leading people not to get vaccinated. One challenge now is the mutations of the virus. The RNA viruses like SARS-CoV-2 mutate. They mutate a lot, and the mutations that are the Darwinian winners, the ones that in fact have greater transmissibility, win out when they go into competition with the other strains. So this is just sort of a phylogenetic map of the evolution of these different strains. And then on the right is the spread of these strains worldwide. So how did a variant first identified in India end up in Mesa County? Well, I think what that shows is that globalization will put these everywhere. So this is the data for the state. The B.1.617.2 is the new Delta variant, and you can see that it's growing. That's this lighter gray. So the variants have changed over time. The so-called UK variant, the B.1.1.7, now the Alpha variant, is dropping. And again, this is probably because the Delta variant is more transmissible. So here's a little bit about the Delta variant. And I think these are data from the UK. And probably what is most worrisome is this very rapid rise of the Delta variant in the UK, quickly taking over as the dominant strain and coming with possibly greater lethality and perhaps lesser, our current vaccines are not as effective against it. So last slide, where do we go? What's going to happen? And, ideally, epidemics come to an end when we reach so-called herd immunity. That is, enough of us are immune so that one person who's infected cannot cause more than one case, so that the epidemic propagates. So that's the idea of herd immunity. How much immunity we have to get there, a little bit of a matter of speculation, but probably in the range of 80% immune from vaccination or from infection. It's very likely that the SARS-CoV-2 will become endemic. That is to say, it'll stick around and be with us. Vaccination may become routine, and variants are inevitably going to remain a concern. And then, words from Dr. Fauci, again, I mean, the clue to bring things as quickly as possible to an end, vaccination is critical. So that is it. And I'm delighted to speak with you. Actually, I think my last slide, and I will make sure via Cassidy, you have this. It's just a set of resources we put together. My weekly column, I've been writing about the pandemic, a data science website we put together with data targeted at the counties, our modeling reports, and then this series that I'm very proud of that we did with the Denver Museum of Nature and Science. So again, thank you very much for the opportunity to speak with you, and thanks for your support for the school.
Great, thank you very much. We have a number of questions, Dr. Samet, and the first one is John Kotke. John, would you mind going ahead and unmuting yourself, ask your question?
Thank you. Dean Samet, it was wonderful to hear from you today. I just want to say first that I also have a 7-year-old grandson, and if he suggested that I needed to move where he was, I think I would respond. The big difference, though, is I would be going from Colorado to Florida, and so that's a little tougher. But I appreciate the recruiting that your grandson did for you. My question is a little personal. I'm a past president of the club, and we have we have past president greeters, and as you heard, we're going to have a live meeting next week, and I get to be the past president greeter at our first live meeting in a long time, and I'm a hugger. And so my concern is it going to be appropriate for me to hug Rotarians as we meet for a live meeting, or should I be holding back on my hugs? I would appreciate whatever advice you can give me.
Well, so the first question is vaccination, and are you expecting that everybody who comes in person will be vaccinated?
Okay, my wife and I are fully vaccinated, and I assume most everybody is, but perhaps that would be a question I should ask.
Well, you should think about it as a club. So I can tell you, we're grappling with the same issue on a larger scale as we bring our schools back on the campus. And on the Anschutz campus, it's going to be required that you are vaccinated, unless you have a genuine medical or religious exemption. And for those who are not vaccinated, there will be requirements around masking and distancing. So, I think as a first point, you should think about, going back in person, and do you say that we welcome everybody and come in person if you're vaccinated,
okay,
and hang out on Zoom if you are not.
Got it.
And I think you ought to think about that because if you have people who are unvaccinated, the safe thing to do is to have them wear a mask and to be distanced. And then they're standing out from everybody else, which they may not want to do.
Yeah.
So, I now back to hugging. I think if everybody's vaccinated, hug away. I mean, it may not be what CDC says, but I think you're okay. I've certainly gotten into back to doing the things we like to do.
Great.
But you got to think about the policy around vaccination, who comes.
Got it. Thank you so much.
Sure.
Thank you, Dr. Samet. And we have a question coming up too, and a couple people down about the CDC. So we'll get to that in a second. Hans, why don't you go ahead and ask your question? Hans, are you there? You got to unmute yourself if you're there. I can't see if you're here. Okay, Hans, we're going to move on. The next person would be Bill Anderson. Go right ahead, Bill Anderson.
Thanks for coming to speak to us, Dr. Samet. I have a 12-year-old and a 10-year-old. My 12-year-old got vaccinated the first day he was allowed to at Boulder Community Health, but my 10-year-old obviously has not been eligible yet. I'm wondering if you have any insight into when the eligibility will occur.
Well, yeah. So I'm sure the vaccines are probably going to be, there's no reason why they shouldn't be approved, but it's getting the trials done and they're in progress. I've heard, sort of late fall, that sort of time frame for the next wave of vaccine trials. And I think they're going now down under 4. So I think you're probably going to have to wait, roughly that long. It's to come still.
So likely until after school begins.
It's going to be after school begins for sure. Yeah. Yeah. Which, I mean, again, the schools are trying to figure all this out too. It's a complicated world.
Indeed. Thank you.
Great. Thank you, Bill. Thank you, Dr. Samet. Next up is Daryl Brown. Go right ahead, Daryl.
All right, so I'm going to throw my voice over to Sally's monitor here because I didn't turn on my microphone. Anyway, so Kotke, first off, I'm going to give you a big hug, okay? I've been man hug, but I'll be hugging you because I've been vaccinated as well. And Doctor, respectfully, there's been so much, I guess, described as controversy, I guess, in terms of the CDC's handling of the pandemic. I don't necessarily want you to give a critique, but could you make some comments on it?
Yeah, well, you can't talk about the CDC without talking about the government response in general and, where the CDC was pushed. And, clearly there's a demarcation between the prior administration and the new one. This is it's a really important question you're asked, and without probing it in every way, certainly political considerations became very involved with the CDC in ways they shouldn't have been. And I think the public health data and the messages were probably not those that wanted to be heard by the prior administration. I think CDC has a lot of rebuilding to do. I think a lot of credibility was lost with the public, with the public health communities, with the science communities. There were things that they did wrong from the outset. I mean, of course, the fiasco initially with testing, for example, which was an area that sits firmly with CDC. I write this weekly column, and if you go look at last week's, or the one that came out Monday, I did actually write about CDC. And an interview with Rochelle Walensky, the new director, and an editorial by Ann Shuckett, who's been deputy director, a wonderful public health person. Take a look, and I guarantee we're going to see lots of postmortem examinations of the CDC and the response of the government at all levels. I mean, you could go to California, for example, and dig in the controversy. I mean, I think Colorado, has been, certainly at the local level, there's been a lot of controversy about public health interventions, and some counties are more difficult than others. But I think we certainly have not gone through the kind of experience, say, that California and some other states did. It's gone well, I think.
Great, thank you. Next question, John Sullivan. Go right ahead, John.
Thanks, Mike. Dr. Samet, you touched on this earlier in your presentation, but I read as recently as this morning that this Delta variant of the COVID-19 virus is increasing. The incidence is increasing in other parts of Colorado, particularly rural areas and Mesa County, among unvaccinated Coloradans. And I'm wondering, as a vaccinated Coloradan living in Boulder County, how concerned should I be about this?
Yeah, I mean, so this is going to keep, and I've tried to allude to that at the end, this is probably going to keep coming up as, we generate more and more variants, and they're inevitably going to be more and more transmissible. At this point, there seems to be, and look, we're just really getting in data now, but we're tracking this really closely, and there's a slight reduction, it appears, in vaccine effectiveness against the Delta variant versus, the wild strains that against it, which was tested, the wild type strains. It's not very much, And so, if you were sort of asking me, Doc, should I get worried and go back in the house? I'd say no. And I would say, keep going as you have been. I think probably more worrisome would be if we had strains that came along with a far greater reduction in effectiveness. Then we really do have to all be worried. But I think right now, I'd say continue as you were.
Great. Jared Rice, you've got a good question. Go ahead, sir.
Thank you. You mentioned that the Colorado School of Public Health worked with Colorado Public Schools, and I'm sure other state agencies to help them develop their mask policy and their pandemic response. You touched on it a little bit, kind of the interplay between politics and medicine and science here, but my question is really about informing your recommendations. Is it the public health professionals' responsibility to help balance kind of the medical healthcare considerations against the political, public opinion, and other kind of perceptual issues? Yeah.
So I understand the question well, and it's often come to me in terms of the public health measures which save lives and the economic consequences which certainly affect health and well-being for many, and some more than others. To me, we help with those kinds of decisions. We have put together economic data, for example, indicators at the county level on sales tax revenues, other kinds of indicators that may be useful for the decision makers. We are not the decision makers, in the end. It sits with, Colorado is with local authority, with the local public health agencies on the measures, the governor to provide guidance. And of course, at the national level, all these discussions have gone on. And, I think probably part of the complication is the difficulty of the question you raise is where people see that balance. There's not agreement on where it should be, and, how much we let the economy go down versus how many lives we save. It's a really complicated exchange. And of course, over the pandemic, it's changed. So we're certainly cognizant of what you're getting at. And, able in the end, we're not making a decision and then the governor is mouthing it. I mean, it's the political decision makers that are doing that in the end, and his professionals, CDPHE and others, of course.
Just kind of as a quick follow-up, does your curriculum at the school kind of help prepare students for the kind of ethical, political, and practical considerations of that kind of tension and balance between the science and
we try and bring all those issues in, and there's various courses that would focus more specifically on it. I have to say, having been at this a long time, there's nothing like getting into the fire to figure out what's really going on. And, early in my career when I was involved in, for example, the secondhand smoke wars, or I was very involved in uranium mining, health and safety, and radon. There was a lot of exactly what you're talking about, and you learn by being there.
Okay, Dr. Samet, we have a couple more questions, but remember how I promised I'd make sure that you were at your 1 o'clock meeting on time?
Yeah.
Well, I screwed up. So
let me go on for a minute or two more, and then I've got to duck, if that's okay.
Great, good answer. I love it. So we've got the next question from Ruth Urban. Go ahead, Ruth.
Hi, actually, it's from Rich.
Actually, what our question has been with a lot of different people is this going to be like the flu, in that you get your shot and then you get another shot down the road because of the way it has changed? So most of us are thinking that this is our vaccination. The first one is one of several.
Likely to be true. Yeah. I mean, I think that's what I was getting at when I said the virus could be endemic, as are other coronaviruses. There are 4 that contribute to the chronic cold. And as we know, the virus is going to mutate. It will change. There are some reasons, and I'm not an immunologist, but the target here is the spike protein on the virus. And it may take major mutations to change how that spike protein works in a way that the vaccines that we have now won't work. They all target the spike protein. So you are pointing to a future scenario. I suspect we will need boosters one way or another. So yes. And maybe I can fill one more question, Mike, and then.
Yes, absolutely. Last question will be Ben. Go right ahead, Ben.
Well, thank you. I first want to introduce that I am a graduate of the University of Michigan School of Public Health.
Great.
And for those Rotarians not knowing the history of my school, in 1955, at the front door of my school was announced the efficacy of the polio vaccine.
Right, Tommy Francis.
Yep, exactly. Anyways, one of the things that I've experienced throughout my career that I've always found to be a challenge is the lack of education around statistics. Even in the medical world, I find myself oftentimes educating scientific professionals on what a p-value means. I'm curious, particularly in this world where trust is fully dependent on source of information, what you see public health's role is in educating those who may not even trust what you're telling them.
So great question. And, you know, I mean, there's an awful lot of work on how do we communicate? How do we communicate about risk? We keep saying it's tough, and that's true. You know, from my point of view, our part of our mission as a school is to communicate. And, you know, a great example, and as I mentioned, is our series with the Denver Museum of Nature and Science, which was oriented to the public and was seen by many, many folks. I think we continue to do a bad job at communicating about risk, and I think we are all challenged to, you know, whether it's in a patient encounter or the public health level, to explain what these numbers mean. We keep trying to do better, and hopefully we will get there. So I think with that, I probably better get to my next meeting. And again, my thanks, and thanks for your support.
Great. I was wondering if you had maybe 30 seconds for Valerie to thank you. Would that be 30 seconds? I promise. Go right ahead, Valerie.
All right, that's just fine, Valerie.
Yeah, so thank you so much, Dr. Samet. That was wonderful. And I want to use a little time to thank all the public health workers out there, because, you know, everybody was focusing on the so-called frontline workers. And I think they didn't realize how much public health workers are doing. And some of them were even threatened in their communities. So thank you to all of them. And as you know, Rotary's been working on eradicating polio for many, many years. We're down to 2 endemic countries, Afghanistan and Pakistan. And in your honor, we would like to donate 100 doses of polio vaccine to the worldwide eradication effort.
Well, thank you, and I'm very grateful, and I'm hoping we will get through those last countries. I mean, such a complex story, and you know, I hope we'll get there. And 100 doses into the right people will make a difference. So thank you.
Thank you.
Okay, goodbye all, and I hope to see you here and there in Boulder.